Which would you rather have? Severe asthma, well controlled, or mild asthma, very poorly controlled? I'm legally blind in my right eye. I take my glasses off all the time. I tell kids I can't drive a car and I can't see my friends from 6 feet away without my glasses. But I am not visually impaired. I have lenses and I have 20/20 vision. But if I'm stubborn or forgetful or neglectful and don't wear glasses, I'm in a world of hurt. Okay, I will not get home. So we as healthcare professionals need to help people understand that there's a process we go through to figure out how much asthma you have, but the end point should be the same for everyone, which is well-controlled asthma. That means you win races, you sing songs, you dance, you sleep all night, you do all the things everybody else does. Do you think the general public knows that or believes that? Not at all. So part of what we do when we message people, either as clinicians or educators or school nurses or pharmacists, is say, you're not supposed to be like this. This is not the way it is supposed to be. There's something else that we need to do. We're missing something here. So regular checkups are aimed at moving you towards well-controlled asthma and reducing your need for medication. So good asthma care is characterized by starting at a high therapy step and moving your way down. And over time, you get down to low steps, one medicine inhaled, relatively inexpensive compared to the cost of poorly controlled asthma. So you saw in your tables there the guidelines. Here's what I really want to point out. As a clinician, I'm told that when I make these determinations, when I'm trying to figure out which therapy step you need to be on, that there are specific steps I should go through. First of all, I would only step you up to a higher level if I needed to. But before I do that, I'm supposed to check to see if you're really using the medications that we had suggested you be on. So we're back to this issue of claims data. For a really good history, close relationship with a patient who's going to be honest with you, you know, I take that medicine maybe twice a week. So I'm not going to add another medicine to your regimen. I'm not going to go to combination therapy. I'm not going to step up your dose. I'm going to say to you, I'm going to give you a key message. Here's the key message. In order to bring your asthma under control, you are going to need to breathe an inhaled corticosteroid into your lungs correctly twice a day, every day, for how long? Somebody's got to be brave. If we don't know, that's a problem. Okay? 2 to 3 months. Okay? And it's 2 to 3 months because people with inflammation due to asthma have lost cilia. They have an army of white blood cells, eosinophils, parked in the airways. They have inflammatory mediators that have built up to really high levels. And it takes twice a day, every day, for 2 to 3 months to shut down the inflammation, regrow cilia, and have normal airways. So I think we can all agree part of the problem is we haven't been clear with our patients. We haven't said to them, this is going to be a big commitment for you. You're going to have to do this twice a day, every day, and not just push down on the inhaler and take a gasping breath in, but I'm going to show you how to breathe the medicine in right, and you will notice a difference in less than 2 months, but it's going to take 2 to 3 months for you to get back to normal airways. Okay, so we all accept if I break my leg, I'm not going to get a treatment and be well next week. But we have not communicated to people with asthma that it's a 2 to 3 month healing process, and that the medicine that shuts down the inflammation is called an inhaled corticosteroid. So if you're taking your medicine and if you know how to breathe it in your lungs and I still don't have your asthma well controlled, I need to think about the environment. Okay? And the reason that's true is it is so rare that people don't respond to those 2 steps, ICS in the lungs twice a day, every day, 2 months, that there must be another reason. The guidelines go on to say as well, don't forget comorbidities. Think about gastroesophageal reflux. Think about allergic rhinitis, obesity, obstructive sleep apnea. All of these things are enemies of asthma control. The glaring thing that we have missed from Sherry's slides you saw, we are not spending healthcare dollars on the right drug. We are spending most of our healthcare dollars on medications that will never stop the inflammation of asthma. And my goal in treating people with asthma is to be able to manage your asthma with the least amount of medication possible. So really good inhaler technique, really knowing how to get that medicine in your lungs and using the right dose of an ICS is going to make the difference. So ICS is the preferred medication for persistent asthma for all age groups. And people need to know it's the only medicine that's shown to essentially eliminate the risk of death due to asthma. This was a New England Journal of Medicine article published in 2000. So you'd have to ask the question, what's wrong here? Why are we not prescribing inhaled corticosteroids more often, and why are our patients not using them as often? What do you think the main reasons are? Cost? How many people feel like cost is a major barrier? It is. There's definitely a group of folks who cost is going to be a big barrier. So part of our role is to help people who do not have insurance navigate the available services. And there's, I think, currently about 5 different foundations or programs that are helping people who do not have funding sources. We need to be up on those. They change from month to month, year to year. We need to know what those are. What's the other barrier? Just the habit, just not taking it. So you've got the medicine. I talked to one mom recently and I said, good for you. We see you're picking up the Advair every month. And she said, oh yeah. And it's all laying on top of his dresser. She had 8 or 10 boxes of Advair HFA and he just wouldn't take it. And she kept picking it up. I said, don't pick up anymore. Let's have this conversation. Why are you not using this medicine? I don't get it. And so we talked about why he didn't think it was worthwhile for her to pick that up. Why else? Pardon? Side effects. People worry about side effects. Okay. And is that a legitimate worry? Okay. And what would you say the main worry with side effects would be? What side effect were you thinking about? Okay. So you're worried about stunting, growth stunting. So we need to be honest with people and say what we know about side effects. So let's talk about messaging around inhaled corticosteroids just for a second. When we look at claims data, what we see is people with persistent asthma who don't get inhaled corticosteroids at a reasonable dose end up taking a lot of oral steroid bursts. Everybody agree with that? You find that believable? It's kind of this revolving door. They get a Z-Pak and they get prednisone or methylprednisolone. It happens time and time again. So compare for me the dose of inhaled corticosteroid with oral steroids. So oral steroids or any form of systemic steroids are milligrams, right? And are they targeted to the lung or are they systemic? When we give inhaled corticosteroids, it's micrograms, okay? And what's the target? Do you get some in the blood? Sure you do. But it's a minute amount. So the bioequivalence of systemic steroids versus inhaled is that you would need to take an inhaled steroid twice a day for about 3 years to get the same adrenal exposure you get from 5 days of dose-appropriate prednisone. Now, there's ways to say this to families, to say, you know, and I've had parents say, I don't want my kid on steroids. And I said, you know, we looked back and he's had 4 oral steroid bursts since May. That's 8 to 12 years worth of inhaled steroids and a lot of anxiety, being in the emergency room, having to take neb treatments, you know, every 4 hours. So that's pretty important. So if we compare